You've been taking your medications every single morning for years. You trust them. Your doctor prescribed them. Your pharmacist filled them. The label says to take them, so you do. But what if I told you that 5 of the most commonly prescribed medications in America carry a risk that rarely appears on the label, rarely comes up during your 10-minute appointment, and becomes significantly more dangerous the moment you cross the age of 60? This isn't about fake medicine. This isn't about conspiracy. This is about pharmacology, about what happens inside an aging body when certain drugs interact with blood vessels, heart tissue, and kidney function in ways that are well documented in published research but almost never communicated directly to patients. If you are between 60 and 75 years old and you take any medication, any prescription at all, stay with me for the next 20 minutes. What I'm about to share could literally change what happens to you the next time you walk into your doctor's office. My name is Dr. Elena Marsh. I spent over 2 decades practicing internal medicine and seeing patients through some of the most frightening moments of their lives. Moments that, in many cases, did not have to happen. I've sat across from patients who did everything right. They exercised. They watched what they ate. They took every pill on schedule. And still they ended up in the emergency room. What I learned over those 20 years is this: it wasn't always the disease that hurt them. Sometimes it was the treatment, not because the treatment was wrong, but because no one had taken the time to explain the risk profile as the patient aged, as their kidney function changed, as their other medications multiplied. A 2022 study published in JAMA Internal Medicine found that adverse drug events in adults over 65 are responsible for more than 700,000 emergency room visits every year in the United States. 700,000. And the researchers noted that a significant proportion of those visits were preventable, not through stopping the medications, but through better monitoring, dose adjustment, and patient education. That's why I'm here. Because the 10 minutes your doctor has with you isn't enough to cover this, but 20 minutes with me is. I want to tell you about a woman named Sarah. Sarah was 67 years old when I first met her, retired engineer, sharp as a tack. She walked into my clinic not because she felt sick, but because her husband insisted. He'd noticed something. She seemed slightly slower in the mornings, a little more breathless than usual when they walked the dog. She was dismissing it as just getting older. Sarah had been on 3 medications for about 4 years: a common blood pressure drug, an over-the-counter anti-inflammatory she'd been using for chronic knee pain, and a medication her previous doctor had prescribed to help her sleep. When I reviewed her chart, I wasn't looking at anything unusual. These were normal medications, common prescriptions, nothing that would raise an immediate red flag in a standard review. But I ordered a full metabolic panel, which her previous doctor hadn't done in nearly 18 months. And what came back stopped me cold. Sarah's kidney function had declined significantly. Her potassium levels were elevated, and her resting blood pressure, despite being on medication, was fluctuating in a pattern that suggested her cardiovascular system was under stress that wasn't being captured by routine measurements. Here's what frightened me most. Sarah had no idea. She felt fine. A little slower, yes. A little more winded. But nothing that screamed emergency. Nothing that said, your body is sending up warning signals right now. The combination of medications Sarah was taking, individually unremarkable, collectively dangerous, was creating a compounding effect on her kidneys and her heart that had been building silently for over a year. If her husband hadn't pushed her through my door, Sarah might have gone another 12 months before something catastrophic happened. A heart attack, a stroke, or simply a fall. A sudden spike in blood pressure, a moment when her body's fragile equilibrium gave out. She was lucky. She came in when she did. But luck is not a medical strategy. The 5 medications I'm going to walk you through today are responsible for patterns I have seen repeated across different patients, in different cities, year after year. They are not rare. They are not obscure. You may be holding one of them in your hand right now. And the thing that makes them dangerous isn't what they are. It's what your body becomes after 60. And why no one told you the rules changed. Here's what changes at 60 that your prescription label will never tell you. Your kidneys filter everything. Every pill you swallow, every compound your liver breaks down, every waste product your cells produce, it all passes through your kidneys. And your kidneys, like every other organ in your body, age. By the time most people reach 65, kidney filtration rate has declined by 30 to 40% compared to what it was at 40. This is normal. This is expected. But it is almost never factored into medication dosing in the way it should be. What this means in practical terms is this. A dose that was safe for your body at 55 may linger longer, accumulate faster, and reach higher concentrations in your blood at 68. The drug hasn't changed. Your body has. Now add to that a second factor, arterial stiffness. After 60, the walls of your blood vessels lose elasticity. They become less flexible. This means your heart has to work harder to push blood through them. And that any drug that affects blood pressure or fluid balance is operating in a system that has far less tolerance for error than it did a decade ago. These two factors, reduced kidney clearance and arterial stiffness, are the biological foundation for everything I'm about to tell you. Keep them in mind. Medication number 1, NSAIDs, non-steroidal anti-inflammatory drugs, ibuprofen, naproxen. These are sold over the counter. Millions of Americans over 60 use them regularly for arthritis, back pain, joint pain. They seem harmless because you can buy them without a prescription. Here is what they do inside your body that the packaging does not explain. NSAIDs inhibit a class of enzymes called cyclooxygenases, COX1 and COX2. These enzymes don't just regulate inflammation. They also help maintain blood flow to the kidneys. When you suppress them with an NSAID, you reduce renal perfusion, the blood supply to the kidneys. In a young, healthy person with strong kidney function, this is a temporary and recoverable effect. In an adult over 60 with already reduced kidney filtration, it can push the kidneys into acute stress, and it can cause sodium and water retention that directly raises blood pressure. A study published in the British Medical Journal in 2017 followed over 446,000 patients and found that regular NSAID use was associated with a 19% increased risk of acute heart failure hospitalization, with the risk highest in adults over 65. 19%. From something you can buy at any pharmacy without a prescription. And here is where it becomes compounding. If you are already on a blood pressure medication, which many people Sarah's age are, NSAIDs can directly blunt that medication's effectiveness. You are taking one drug to control your blood pressure and another drug that quietly pushes it back up. Medication number 2, certain blood pressure medications, specifically alpha blockers. Alpha blockers like doxazosin and terazosin are prescribed for high blood pressure and, very commonly in men, for enlarged prostate. They work by relaxing the muscles in blood vessel walls, allowing vessels to widen and blood pressure to drop. The problem after 60 is a condition called orthostatic hypotension, a sudden drop in blood pressure when you stand up. Here is the mechanism. When you're lying down or sitting, blood pools slightly in the lower body. When you stand, your autonomic nervous system, the part of your nervous system that handles automatic functions like heart rate and blood vessel tension, normally responds within seconds, constricting vessels and slightly increasing heart rate to maintain blood flow to the brain. As we age, this autonomic response slows. The adjustment that used to take 1 second now takes 3 or 4. Alpha blockers slow it further. The result is a window of several seconds, sometimes longer, where blood pressure drops sharply and the brain receives less oxygen than it needs. You feel this as dizziness, as lightheadedness, sometimes as a sudden need to grab something to steady yourself. Many people over 65 chalk this up to standing up too fast. They don't realize it's a drug effect, one that significantly increases fall risk, and one that, in more extreme cases, can cause a transient ischemic attack, a mini stroke. A 2020 analysis in the Journal of the American Geriatric Society found that orthostatic hypotension in adults over 65 was associated with a 40% increased risk of cardiovascular events over a 5-year follow-up period. Not a minor risk, not a theoretical risk, a 40% increase. Medication number 3, proton pump inhibitors, PPIs, omeprazole, pantoprazole, esomeprazole. These are among the most widely prescribed medications in America. They reduce stomach acid. They're used for acid reflux, GERD, and ulcer prevention. And they are taken long-term by tens of millions of adults, many of whom started them years ago and simply never stopped. Here is what long-term PPI use does that almost no one talks about. PP is reduce the absorption of magnesium. Magnesium is not a supplement trend. It is a mineral that plays a direct role in cardiac electrical activity, in the rhythm of your heartbeat. Low magnesium levels are associated with arrhythmias, irregular heart rhythms that in their more serious forms can precipitate stroke and cardiac arrest. A study published in Circulation, the flagship journal of the American Heart Association, found that long-term PPI use was associated with a significantly elevated risk of cardiovascular mortality, particularly in adults who had been taking them for more than 2 years. 2 years. Many people have been on PPIs for a decade. Additionally, PPIs reduce the absorption of vitamin B12 over time. B12 deficiency in older adults is associated with elevated homocysteine levels, and homocysteine is an independent risk factor for atherosclerosis, the hardening and narrowing of arteries that leads to heart attack and stroke. 1 pill for your heartburn. 2 downstream pathways toward your heart. Before I continue, I want to pause here for just a moment. Quick question before we go further. Are you currently taking any of the medications I've just mentioned? An anti-inflammatory, a blood pressure drug, or a PPI for acid reflux? Write yes or no in the comments right now. I read every single one. I want to know how many people watching this are carrying one of these in their medicine cabinet today. Medication number 4, certain antidepressants, SSRIs and SNRIs. This one surprises people. Antidepressants are not medications most people associate with heart risk, but the cardiovascular effects of some SSRIs and SNRIs, selective serotonin and serotonin norepinephrine reuptake inhibitors, are real, documented, and under-discussed. Here is the mechanism that matters most after 60. Serotonin plays a role not just in mood, but in platelet function. Platelets are the blood cells responsible for clotting. SSR is reduced serotonin uptake in platelets, which can impair the clotting process. In most adults, this is a minor effect. But in an adult over 60 who is also taking a daily low-dose aspirin, which is extremely common, the combination can significantly increase bleeding risk, including the risk of hemorrhagic stroke. A stroke caused not by a clot, but by a bleed inside the brain. A 2020 study in JAMA Network Open found that concurrent use of SSRIs and antiplatelet medications like aspirin in adults over 65 was associated with a substantially increased risk of major bleeding events, including intracranial bleeding. This is not a reason to stop your antidepressant. Depression is a serious medical condition, and these medications save lives. But if you are on an SSRI and also taking aspirin daily, that combination needs to be reviewed with your doctor, specifically in light of your age and your overall cardiovascular profile. Medication number 5, sleep medications, particularly benzodiazepines and Z drugs, lorazepam, diazepam, zolpidem. These are prescribed widely for anxiety and insomnia. They are also, according to the American Geriatric Society's Beers criteria, a published guideline specifically designed to identify medications that are inappropriate for older adults, explicitly listed as drugs to avoid in people over 65 whenever possible. Why? Multiple reasons. But the one most relevant to cardiovascular risk is this: these medications suppress respiratory drive during sleep in adults who already have any degree of sleep-disordered breathing, which is extremely common over 60, even in people who haven't been diagnosed with sleep apnea. Sedative medications can deepen that suppression, causing repeated episodes of low blood oxygen overnight. Every episode of low oxygen is a stress event for the heart. The heart responds to hypoxia by working harder. Blood pressure spikes. The sympathetic nervous system activates. Night after night, undetected, this pattern creates cumulative cardiovascular strain that shows up eventually as hypertension that's difficult to control, as arrhythmias, or as the kind of silent cardiac remodeling that precedes a serious event. A large-scale study published in Sleep Medicine Reviews found that hypnotic medication use in older adults was associated with increased all-cause mortality, with cardiovascular causes among the leading contributors. You took it to sleep better. Your heart paid the price in the dark. Now I want to step back for a moment because there's something that connects all 5 of these medications that I haven't said explicitly yet. It's not the drugs themselves, it's the combination. Most adults over 60 who are on medication are not on one medication. They are on 3, 4, 5, sometimes more. This is called polypharmacy, and it is one of the most significant and least discussed risks in modern medicine for older adults. Here is why this matters beyond anything I've described so far. Each of the 5 medications I walked you through has its own risk profile. But when you combine them, when a patient is taking an NSAID for knee pain, a PPI for reflux, an SSRI for depression, and a sleep aid at night, something happens that no individual drug study fully captures. The risks don't simply add together. In many cases, they multiply. This is called the drug interaction cascade, and it is responsible for a pattern I saw over and over in clinical practice. A patient whose individual medications all seemed reasonable, whose labs were reviewed in isolation, but whose overall pharmacological burden, the total chemical load on an aging body, had quietly crossed a threshold that no single prescription could account for. A 2019 study published in The Lancet examined nearly 1.3 million older adults across multiple countries and found that patients taking 5 or more medications simultaneously had a 35% higher rate of serious adverse events compared to those on fewer than 3. 35%. And the risk increased linearly with each additional medication added to the regimen. 5 medications, 35% higher risk. That is not a footnote. That is a headline that should be on the front page of every patient's discharge summary. Here is the secondary threat I want you to understand, and it is one that almost no one talks about in the context of medication risk. It is called the prescribing cascade. The prescribing cascade works like this. A medication causes a side effect. That side effect looks like a new medical condition. A doctor, often a different doctor than the one who prescribed the first medication, treats that apparent new condition with another medication, which causes its own side effects, which get treated with another medication. Let me give you a specific example. A patient starts taking an NSAID for joint pain. The NSAID causes fluid retention, which raises blood pressure. The elevated blood pressure gets treated with a new antihypertensive. That antihypertensive, an alpha blocker, causes dizziness upon standing. The dizziness is interpreted as a possible inner ear problem or early neurological symptom. A medication is prescribed for that. which causes dry mouth and mild cognitive dulling, which gets noted in the chart as possible early cognitive decline. One pill became 5. One joint pain became a neurological workup. This is not hypothetical. This is a well-documented clinical pattern, and it disproportionately affects adults over 65 because older patients are more likely to see multiple specialists, more likely to have the side effects of one medication resemble the symptoms of another condition, and more likely to be prescribed something new rather than have an existing medication reconsidered. The solution is not to stop taking your medications without medical supervision. The solution, and this is critical, is to become the person in the room who asks the question that most patients never think to ask. I'm going to give you that question. And 4 others. Together, they form what I call the 5-question medication review, a protocol you can bring to your next appointment that will take your doctor less than 5 additional minutes but could fundamentally change your safety profile. Write these down or screenshot this screen, because these are the questions that I wish every patient of mine had walked in asking from the very beginning. The 5-question medication review. Step 1. Ask about your kidney function. Say this: given my age, has my kidney function been tested recently? And has anyone looked at whether my current medication doses are appropriate for my current kidney filtration rate? Most standard blood panels include creatinine, which gives an indirect measure of kidney function. But the calculated filtration rate, the eGFR, is what actually determines whether your medication doses are still safe. Many patients are on doses calibrated for kidneys that functioned at 40. Their kidneys are now functioning at 65. No one recalculated. This question takes 30 seconds to ask. The answer could change everything. Step 2. Ask for a complete medication reconciliation. Say this: can we go through every medication I'm taking, including over-the-counter drugs, supplements, and anything I take occasionally, and look at whether any of them interact in ways that affect my heart or kidneys? This is called a medication reconciliation. It is a standard clinical practice that is surprisingly underutilized in outpatient settings. Your doctor or pharmacist can run your complete medication list through an interaction checker in minutes. What comes back is often illuminating and sometimes alarming. Bring a written list of everything you take. Everything, including the ibuprofen you take twice a week for your shoulder, including the melatonin at night, including the fish oil. Everything enters your bloodstream. Everything matters. Step 3. Ask about orthostatic blood pressure. Say this: can you check my blood pressure both lying down and standing up? I've read that the difference between those 2 readings can reveal cardiovascular risk that a standard seated measurement misses. This is called an orthostatic blood pressure check. It takes 90 seconds. It requires no equipment beyond a blood pressure cuff, and it can reveal orthostatic hypotension, that dangerous drop in pressure when you stand, that standard office measurements completely miss because they're always taken while you're seated and still. If you are on an alpha blocker, a diuretic, or any medication that affects blood pressure, this check is not optional. It is essential. Step 4. Ask the still necessary question. Say this: is each of these medications still necessary at the dose I'm currently taking, or are any of them something we started years ago and haven't revisited since? This is the question most patients are afraid to ask because they don't want to seem like they're challenging their doctor. But it is one of the most clinically important questions you can raise. Medications get started for specific reasons at specific moments in a patient's history. Circumstances change, conditions improve, alternatives emerge, but prescriptions rarely get canceled on their own. They accumulate. Your doctor will not be offended by this question. A good doctor will welcome it. Step 5. Ask about monitoring frequency. Say this: given the medications I'm on, how often should I be getting blood work to check my kidney function, electrolytes, and any markers related to cardiovascular risk? For adults over 60 on multiple medications, annual blood work is often not enough. Kidney function, potassium levels, magnesium levels, B12, these can shift meaningfully in 6 months. If your last comprehensive panel was 14 months ago, you are flying without instruments. Ask for a monitoring schedule, write it down, hold your care team to it. These 5 questions will not replace your medical care. They will improve it. They will make you a participant in your own health rather than a passive recipient of it. And they will give your doctor the opening to catch something, a dose adjustment, a drug interaction, a declining lab value, before it becomes an emergency. That is the entire goal, not panic, not distrust of medicine, informed partnership. I want to go back to Sarah. When I last told you about her, she had just gotten her lab results back. Her kidney function was down, her potassium was elevated, her blood pressure was fluctuating in a way that had gone undetected for over a year, and she had no idea any of it was happening. Here is what we did, and I want you to hear this clearly because this is not a complicated story. This is not a dramatic medical intervention. This is what happens when a patient gets the information she deserved to have much earlier. We started with a complete medication reconciliation. We laid out everything Sarah was taking. The prescription blood pressure drug, the over-the-counter ibuprofen she'd been using 3 to 4 times a week for her knee, and the sleep medication she'd been on for nearly 2 years. We ran interaction checks. We looked at her eGFR, her kidney filtration rate, and cross-referenced it against the standard dosing guidelines for each drug. What we found was not shocking. It was entirely predictable. The ibuprofen was blunting her blood pressure medication and stressing her kidneys simultaneously. The sleep medication was suppressing her respiratory drive at night in ways that were creating small but repeated cardiovascular stress events she would never feel and could never see. The combination, over time, had produced exactly the pattern her labs were showing. We made 3 changes. We replaced the ibuprofen with a topical anti-inflammatory that bypassed the systemic kidney effects. We began a structured taper of the sleep medication under close monitoring, with a referral to a sleep specialist to address the underlying insomnia properly. And we added a quarterly lab schedule, kidney function, electrolytes, magnesium, so that nothing could drift silently again. 6 months later, Sarah came back in for her follow-up. Her eGFR had improved. Her potassium had normalized. Her blood pressure readings had stabilized, consistently, not just on good days. And she told me something I have heard from patients in various forms over the years, but that never stops meaning something. I feel more like myself than I have in 2 years. I thought that was just what getting older felt like. I didn't know it could be different. She thought it was aging. It was her medication. That distinction between what we accept as inevitable and what is actually addressable is the entire reason this channel exists. You are not supposed to feel worse every year and call it normal. Some of what feels like aging is aging, but some of it is something else. And some of it can be changed. Sarah went home that day and did something that I think about often. She called her sister, who was 71, on 4 medications, and hadn't had a full metabolic panel in over 2 years, and told her to make an appointment. I don't know what her sister's results showed. Sarah never told me, and I never asked. But I know she made that call, and I know that call mattered. That's what I want to ask you to do right now. Not to panic, not to throw away your prescriptions, not to distrust your doctor. I want you to think of one person, a spouse, a sibling, a friend, a neighbor who is over 60, on at least 2 medications, and hasn't had a full conversation with their doctor about what those medications are doing to their body as it ages. You know someone. You already thought of a face. Send them this video, not because you're worried, because you care, because the information that Sarah's husband accidentally stumbled onto by insisting she come see me, that information is right here, in this video, available to anyone you love who needs it. The 10-minute appointment won't cover this, but this video will. Share it before you close this tab. That one action, sending this to one person, could be the most important thing you do for someone you love today. And if you haven't subscribed to this channel yet, I want to ask you to do that now. Every week, I bring research-backed, clinically grounded information about what your body needs after 60. The information I spent 20 years wishing my patients had before they ended up in my office in crisis. No products, no supplements, no agenda except the one I've had since my first year in medicine. Give people what they need to make informed decisions about their own health. If that is something you want more of, click subscribe. It costs you nothing. And it means the next time I publish something that matters, you'll be the first to know. Before I go, I want to say one more thing directly to you. You watched this entire video. That tells me something about you. It tells me you take your health seriously. It tells me you are not passive about what happens to your body. It tells me you are exactly the kind of person who will actually take the 5-question medication review into their next appointment. And ask. Do that, please. Write the questions down. Put them in your phone. Hand the list to whoever drives you to your appointments if you need to. But bring them. Because the conversation that follows could catch something that has been silently building. The way Sarah's was building. Before it reaches a point where catching it is no longer enough, your body has been sending signals. Now you know what some of them mean, and now you know what to ask. That is not a small thing. That is everything. A quick and important note before you go. Everything I've shared today is based on published clinical research and my own experience as a practicing physician. The studies I referenced are real. The mechanisms I described are established science. But this video is not a substitute for your personal medical care, Yao, and I want to be clear about that. Before you make any changes to your medications, your doses, or your daily routine, please talk to your own doctor first. She knows your history. He knows your chart. They know the full picture in a way that I, speaking to you through a screen, cannot. Take the 5-question medication review into that conversation. Use what you learned here as a starting point, not as a final answer. Good medicine is a dialogue. This video is the beginning of yours. I'll see you in the next one.